So whatever is the cause for causing it will result in sudden onset of the neck pain. Patient will complain of pain in the neck, okay, anterior part of the neck, and there will be tenderness in the glandular area, meaning if you press that area where the thyroid is located, patient will complain of pain, or some facial expression will be there. So that is the tenderness in the glandular area, and patient can have fever. Some systemic features also will be there. Fever with chills can be there, and other signs of infection will be there. Okay, so how to know that patient is having problem in the thyroid? Apart from the systemic features like the fever or chills, there will be sudden onset of the pain in the neck, and there will be tenderness over the glandular area. So infectious thyroiditis may be self-limited or controlled by appropriate therapy. Okay, all the time infectious thyroiditis, they may heal spontaneously. They may be self-limited with or without treatment, or sometimes with some medication it can be controlled. The thyroid function usually not significantly affected, and few residual effects with the small foci of scarring may be present. So when you talk about thyroiditis, there are so many types of thyroiditis. Okay, so within that, number one and most common one we'll be discussing, that is the Hashimoto thyroiditis. So it is also known as chronic lymphocytic thyroiditis, and it is one of the commonest cause of hypothyroidism. You know hypothyroidism, isn't it? What it is? What is hypothyroidism? Anyone? Or should I call the name? Anyone please answer?
Decrease in thyroid hormone T3 T4 level.
Okay. So hypothyroidism is a condition where the serum level of T3 and T4 are reduced. Okay. So and patient can have increase in level of the TSH. So this Hashimoto thyroiditis occurs in areas of the world where the iodine levels are sufficient. Okay, so it is characterized by gradual thyroid failure because of autoimmune destruction of the thyroid. Characteristically, so Hashimoto's thyroiditis means there is inflammation. It is a chronic lymphocytic thyroiditis, and in this case, there is gradual thyroid failure is there because of the autoimmune destruction of the thyroid. Basically, Hashimoto's thyroiditis is an autoimmune condition which is leading to destruction of the thyroid, and it is associated with hypothyroidism. Always remember, in Hashimoto's thyroiditis there is hypothyroidism, and it is one of the cause for hypothyroidism where the iodine levels are sufficient. Okay, normally hypothyroidism occurs where there is iodine deficiency. Okay, it is endemic where the where the level of the iodine is low. But there's one condition, that is thyroiditis, autoimmune thyroiditis, where the thyroid levels are low. That is, a patient will be having hypothyroidism despite the um, sufficient iodine level. The name Hashimoto's thyroiditis is derived from 1912 report of Hashimoto describing patient with goiter and intense lymphocytic infiltrate of the thyroid gland. Okay, so he described that condition as stroma lymphomatosa. That Hashimoto's thyroiditis, that time it was described as stroma lymphomatosa in female with 10 to 20. Okay, so 20 is to 1 to 10 is to 1. The ratio is female to male ratio is 20 is to 1 or to 10 is to 1. So primarily this Hashimoto's thyroiditis is a disease of older women, but it can occur in children also, and it is one of the major cause of non-endemic goiter in children. So, though Hashimoto's thyroiditis, it is an autoimmune condition, genetic component is suggested by the presence of 30 to 60% in 30 to 60% of the cases in monozygotic twins. And also, it is explained by the presence of circulating anti-thyroid antibodies in approximately 50% of the asymptomatic siblings of Hashimoto's thyroiditis. Okay, so that explains that it has not only autoimmune cause, but it has some genetic component is also there. A genetic role is also there for the Hashimoto's thyroiditis. And next is it may be associated with the polymorphism in cytotoxic T lymphocyte associated antigen CTLA4. Okay, so that also explains that some genetic role is there. And also polymorphism in the HLA locus, specifically the HLA-DR3, where there is severe thyroid atrophy, and HLA-DR5. So this pathogenesis of Hashimoto's thyroiditis. So talking about the pathogenesis, an autoimmune disease, it is an autoimmune disease in which immune system reacts against a variety of the thyroid antigens. There's an overriding feature, that is there will be progressive depletion of the thyroid epithelial cells, which is also known as thyrocytes. And gradually it is replaced by the mononuclear cell infiltration, and there will be presence of fibrosis. Okay, so Hashimoto's thyroiditis, it is an autoimmune disease in which immune system reacts against a variety of the thyroid and is also known as thyrocytes. Gradually these are replaced by the mononuclear cells, and there will be fibrosis, presence of fibrosis. So it is an autoimmune disease, so both cellular and humoral factors plays important role in the thyroid injury and subsequently the hypothyroidism. The disease is primarily caused by a defect in the T cell. So you can see here the T cells, there is a mainly defect in the T cell. It plays important role here. The T cells, when they are exposed to the processed thyroid antigens, which are presented by the specific types of major histocompatibility complex, that is MHC, then these T cells gets activated. And at the same time, there is diminished suppressor T cell. Okay, so these activated T cells will go and act on the B cells so that the antibodies are produced. So anti-thyroid antibodies. Okay, and next this activated T cells will transform into helper T cells, and this will also lead to activation or formation of the CD8 T cell. Okay, which is a cytotoxic cell. These are cytotoxic to the thyroid cell, meaning they will directly kill the thyroid follicular epithelial cells. Okay, so you people understand this part. The T cells, once they are exposed to it, once they are activated, they act on the B cell so that antibodies are produced, so that they will be and they will activate the antibody dependent cytotoxicity mechanism, and plus this activated T cells will transform into helper T cell, CD4 helper T cell, and also they will activate CD8 T cell, and these CD8 T cells are cytotoxic to the thyroid epithelial cells. There's another picture. This is from your Robbins function of the thyroid autoimmunity. So that will lead to CD8 cytotoxic T cells. Okay, so which has got direct effect of it will cause it has got a direct effect on the this follicular epithelial cells. Okay, they act through FAS and FAS-L, that is FAS and FAS ligand. They combine to the receptor and then they kill the thyrocytes. So through the CD8, since they are cytotoxic T cell, there is T cell mediated killing of the follicular epithelial cell. Now they release gamma interferon or interferon gamma, which will activate these macrophages. Now this activated macrophage will have the direct effect over the thyrocyte, leading to injury of the follicular epithelial cell. Use the antibodies. Anti-thyroid antibodies will be produced, and they will have again cytotoxicity. Okay, so there will be through the this anti-thyroid antibodies, there will be antibody dependent cell mediated cytotoxicity will be there, leading to killing of the epithelial cells. So these antibodies against this they are not specific for the disease. So the antibodies against the TSS receptors are also present in case of the Hashimoto's thyroiditis. Just like the Graves' disease, the antibodies are also directed against the TSS receptor. But the action is opposite. Like in Hashimoto's thyroiditis, the anti-TSS receptor antibodies, they block the action of the TSH, leading to hypothyroidism. Whereas in case of the Graves' disease, these anti-TSS receptor antibodies, they have a thyroid stimulating activity leading to hyperthyroidism. Okay, so there is a totally opposite action. There are also antibodies which are directed to the iodine transporter present in few of the patient and may lead to hypothyroidism. They may have some role in hypothyroidism. Many thyroid antibodies, this follicular epithelial cells destruction occurs due to the FAS and FAS-L mediated apoptosis. Okay, this is occurring through the cytotoxic T cell, CD8 T cell. So those T cells will mediate the FAS and FAS-L mediated apoptosis, which will lead to death of the follicular epithelial cell or thyroid epithelial cell. Now, what is the gross picture for Hashimoto's thyroiditis? So morphologically, grossly, the thyroid gland is enlarged, the capsule is intact, the gland is well demarcated from the surrounding structures, and on cut section, the cut surface is pale white, pale yellow, tan, form, and somewhat nodular. Okay, so basically the thyroid gland is enlarged, but still the capsule is intact. Okay, and the gland is well demarcated from the surrounding structures, meaning there is no infiltration, there is no attachment to the surrounding structures. And cut surface, if you see, it is pale yellow, tan, and it is firm in consistency, and sometimes it may be nodular. You can see here, this is the cut section of the thyroid gland having Hashimoto's thyroiditis. You can see here pale yellowish in color, some area there is a tan in color, and somewhat nodular. Okay, somewhat nodular, and it is firm in consistency. It is not. So this is the cut section. So histologically, there will be extensive parenchymal infiltration by the mononuclear inflammatory cell infiltrate. So as the name suggests, it is a chronic lymphocytic thyroiditis. So inflammation of the thyroid is there, and mainly by the chronic inflammatory cells. So histologically also you'll see extensive parenchymal infiltration by the mononuclear inflammatory cells, mainly the lymphocytes. But sometimes you can also see the plasma cells, and you can see that there will be germinal centers. And the thyroid follicles, usually they are smaller in size. They are lined by the epithelial cells with abundant eosinophilic cytoplasm, which is known as Hurdle cells. So follicular epithelial cells, excuse me, they are smaller in size and are transformed into Hurdle cells, okay, due to destruction. So these Hurdle cells, these are the epithelial cells. They are transformed, these follicular epithelial cells having abundant eosinophilic cytoplasm. And in the interstitium, if you see, there will be not only the inflammation is present within the capsule of the thyroid gland. And less common variant, small thyroid with extensive fibrosis can be present, which is in sometimes the thyroid may be smaller in size with extensive fibrosis. So you can see this is HNS10 section of thyroid gland having Hashimoto's thyroiditis. Okay, and this is the parenchyma part. You can see these are the follicular epithelial cells, and these are hugely replaced by this mononuclear cell, and they are forming the germinal centers. And these are all follicular epithelial cells of various sized, but usually they are smaller Okay, some are bigger, but most of them, they are smaller, and they are lined by a small cuboidal to flattened epithelial cell, but mostly they are lined by the Hurdle cell. So these Hurdle cells, these are cuboidal cell having eosinophilic cytoplasm. You can see this one also, here also. So mostly these follicular epithelial cells, these are lined by the Hurdle cells. Again, these are florid. You can see these dotted. These are all mature lymphocytes. These are germinal center cells. These are Hurdle cells and follicular epithelial cells having eosinophilic cytoplasm. And these follicular epithelial cells are infiltrated by the lymphocyte. Okay, these lymphocytes are entering into the follicles, and these are present in between the follicles. So you can see there's one lymphocyte, another lymphocyte within the follicular epithelial cells. So these inflammation, these are present here and also entering into the follicle, destroying the follicular epithelial cells, and these follicular epithelial cells will transform into Hurdle cell. Okay, so presence of Hurdle cell will be there. With the painless enlargement of the thyroid with hypothyroidism, and usually they are middle-aged female. So middle-aged female having enlargement of the thyroid, and if you do the T3 T4 test, usually they will be having low level of the T3 and T4 and high level of the TSH. So there will be hypothyroidism. So if those cases are there, then you have to first suspect Hashimoto's thyroiditis. So this enlargement of the thyroid gland, clinically it may be diffuse and symmetrical. So most of the time the enlargement of the gland is diffuse and symmetrical. Hardly any nodules can be there. But if that enlargement of the thyroid gland is localized, then you have to suspect any malignancy. And the hypothyroidism in such patient develops gradually. But sometimes in some of the patients, it may be preceded by transient thyrotoxicosis. Though the patient with Hashimoto's thyroiditis, they present with enlargement of the thyroid gland with hypothyroidism, but initially patient can have transient stage of thyrotoxicosis, meaning they will be having high level of T4 and T3 in their blood. Okay, so that time, since the patient is having thyrotoxicosis, in case of Hashimoto's disease, that time it is known as Hashitoxicosis. And this Hashitoxicosis is caused by the disruption of the thyroid follicles, and so there will be secondary release of the thyroid hormones. Thyroidism supervenes gradually when the patient will develop hypothyroidism. Then T3 T4 the clinical, and the risks which are associated with the Hashimoto's thyroiditis are autoimmune disease and malignancy. If the patient is having Hashimoto's thyroiditis, then there's a risk that patient may develop type 1 diabetes, or they may be autoimmune adrenalitis be there in those patients like SLE, systemic lupus erythematosus, or myasthenia gravis or Sjogren's syndrome. Or sometimes the patient with Hashimoto's thyroiditis may develop malignancies like B-cell lymphoma, okay, non-Hodgkin's lymphoma, or may develop malignancy, mainly papillary carcinoma thyroid. This is very important. So patient with Hashimoto's thyroiditis may have a risk of developing non-Hodgkin's lymphoma, mainly of B-cell type, and papillary carcinoma thyroid. So that is all about the Hashimoto's thyroiditis. Now, so next, inflammation of the thyroid or thyroiditis. We are discussing thyroiditis or subacute granulomatous thyroiditis. It is also known as de Quervain's thyroiditis. And this is less common compared to the Hashimoto's thyroiditis. And the age group mostly affected are 30 to 50 years age. Okay. And again, in this case also, females are more prone to have the subacute thyroiditis than the males. Now, pathogenesis of decorvens thyroiditis or subacute granulomatous thyroiditis, it is believed that it is triggered by by a viral infection. So, majority of the patient presenting with the subacute granulomatous thyroiditis, there is a preceding history of upper respiratory tract infection. Okay, if you ask that whether patient is having any viral infection, they will admit. So patient will be having preceding history of upper respiratory tract infection, and usually because of that, it has got seasonal incidence. So subacute thyroiditis, granulomatous thyroiditis are seen more in the summer season, and it can be associated with the Coxsackie virus, mumps, measles, or adenovirus, and it has got strong association with the HLA-B35 in some ethnic groups. So, subacute granulomatous thyroiditis or decorvin thyroiditis, these are usually associated with the viral infection. That is more important. So, the main pathogenesis here is antigen or thyroid antigen. Then this will stimulate the cytotoxic T lymphocytes. And in case of the patient with HLA-B35, antigen is presented by the macrophages. So this antigen, they stimulate the cytotoxic T lymphocytes, then they damage the thyroid follicular cells, leading to subacute granulomatous thyroiditis. Are you getting me, all of you? Understood? Any questions till now? Are you there? No response? You can unmute your mic and answer.
Yes, ma'am.
Yes,
Okay.
ma'am.
Okay. Not sleeping. Okay, so we are talking about the subacute granulomatous thyroiditis or decorvin thyroiditis. So mainly it is induced. It is believed that it is induced by the viral infection. Okay, where the antigen stimulate the cytotoxic T lymphocytes, leading to damage of the thyroid follicular epithelial cells, leading to the disease. Okay, so generally if the patient presents with a subacute granulomatous thyroiditis, if you ask history, they will give that they were having some kinds of viral infection, mainly the upper respiratory tract infection. So in contrast to the autoimmune thyroid disease, the immune response is virus initiated and not self-perpetuating, so the process is limited. So good thing about the subacute granulomatous thyroid, yeah. Mute your mic, please. All of you, please mute your mic again. So, good thing about the autoimmune, this subacute granulomatous thyroiditis, since the immune response is virus initiated and not self-perpetuating, so the process of the thyroiditis is limited. Okay. So, morphologically, the thyroid gland are either unilaterally or bilaterally enlarged. Either just one lobe is enlarged or both the lobes are enlarged, and it is form in consistency, and there will be intact capsule, but slightly adherent to the surrounding tissue. On cut section, the involved areas, they appear form yellowish white, and they stand out from more rubbery normal brown thyroid substance. Okay, the affected area, they are form and yellowish white, and they stand out from the more rubbery normal brownish colored thyroid tissue. Okay, if the condition is during the early phase of the inflammation, then you'll find scattered follicles entirely disrupted and replaced by the neutrophils forming microabscesses. Whereas later stage, there will be aggregates of the lymphocytes, activated macrophages, and plasma cells. Okay, in the later stage, there will be presence of aggregates of the lymphocytes, activated macrophages, and plasma cells. And the follicles which are present, they are collapsed and damaged. Okay, and there you'll be finding multinucleated giant cells. Numerous multinucleated giant cells will be there, including the naked pools and fragments of the colloid. So the follicles are disrupted, and whatever colloid is there, these are present within the multinucleated giant cells. So depending upon the phase, there will be different morphological features. If it is in the early phase, there will be scattered follicles. These follicles are disrupted and replaced by the neutrophils, forming the microabscesses. Whereas in the later stage, there will be presence of aggregates of the lymphocytes. There will be activities of the colloids. Whereas in more later stage, the chronic inflammatory cell infiltrate and the fibrosis will replace the foci of injury. So these different histologic stages sometimes found in the same gland, suggesting the waves of destruction suggests that the patient, the thyroid gland has undergone waves of destruction over a period of time. So histologically, you can see there are histiocytes. Okay, there are mature lymphocytes. There are these are epithelial cell. These are macrophages. These are transformed into epithelial-like cell. So these are epithelioid cell, and this colloid is there. And there are giant cells. These are multinucleated giant cells. So here they are more or less forming the granuloma. Okay, so the name is given as chronic granulomatous thyroiditis. So thyroid parenchyma, these are replaced by the, or these are infiltrated or macrophages and epithelial cell along with the multinucleated giant cells. And these multinucleated giant cells may be enclosing the colloid. So you can see here again, there are numerous multinucleated giant cells here, and okay, neutrophils are there, but this side there are um, macrophages and epithelial cell. Okay, forming granuloma. These are early phase where there are presence of neutrophils. These are all neutrophils forming microabscesses. Later on, as the disease progresses, there will be presence of mononuclear cell, the lymphocytes, macrophages, epithelial cell, and numerous multinucleated giant cells. There's plasma cell also here. So clinically, patient having subacute granulomatous thyroiditis, that is the main characteristic feature, and also patient can have enlargement of the thyroid, which may be unilateral or bilateral. Okay, patient present with pain over the thyroid with enlargement of the thyroid, and this presentation, it may be sudden or it may be gradual and characterized by pain in the neck, may radiate to upper neck, jaw, throat or ear. So that pain is not localized within the thyroid gland, but this pain may radiate towards the upper neck, jaw, throat, or towards the ear. And particularly the pain may be present while swallowing. And apart from that, sometimes patient may present with fever, fatigue, malaise, anorexia, and myalgia. The thyroid inflammation and hypothyroidism can be there, but it is transient and reduced by 2 to 6 weeks even without the treatment. So those thyroid pain or the thyroid inflammation, along with that hypothyroidism, it may be transient. It will remain there for only few weeks, and these are reduced without treatment also. So these are self-limited. So this transient hypothyroidism occurs usually due to the disruption of the follicular cells, thyroid follicular cells, and leading to release of the excessive thyroid hormone characterized by increase in T3 and T4 and decrease in the TSH. In this case, the radioactive iodine is low because of the TSH suppression. present with pain, because inflammation is going on in the thyroid. Usually they are present with the pain in the thyroid gland, which may radiate towards the upper neck, towards the ear also, throat also, the um, jaw also, and they may complain of those pain, especially when swallowing the food or water. And this inflammation or the pain will remain only for few periods of time, and it may vanish without any treatment. And in the case of subacute thyroiditis, the patient may have transient hypothyroidism, which occurs due to the disruption of the follicular epithelial cells, leading to excessive thyroid hormone release. And this hypothyroidism is usually characterized or followed by a transient period of hypothyroidism lasting for 2 to 8 weeks. But the recovery is complete, and by after 6 to 8 weeks after the recovery, the normal thyroid function is returned. Okay, by 6 to 8 weeks after the recovery, there will be normal thyroid function. Okay, all of you. So this is all about the subacute thyroiditis. Always remember, in case of the Hashimoto's thyroiditis, patient is having the main pathogenesis here is the autoimmune disease. Okay, autoimmune. So Hashimoto's thyroiditis is an autoimmune condition where there is destruction of the follicular epithelial cells by the um, T cells and also the B cells or the antibodies. But mainly T cells plays the role. Whereas in case of the subacute granulomatous thyroiditis, and there is destruction of the follicular epithelial cells. But it is self-limited. Clear, all of you? Any questions? Anyone? Everyone sleeping or what? Clear?
Yes, ma'am.